Good evening, it's Sunday. This is going to be a regular physiotherapy slot for children and adults, so I am happy to take questions and try and solve any problems about adult topics as well. Tonight we are going to particularly look at exercises and contractures, around 45 minutes on each. I particularly want questions about any problems that you've got. There's no point in me just talking if it's not answering the problems that you have. I can't answer everything. I can't tell you everything your physiotherapist should be doing or how often, but I think the important thing is that we get an overview on what's important. What are the priorities? Life is not about physiotherapy. Physiotherapy has got to fit in around what you're doing. So it is Diwali. You will hear a few claps and bangs in the background, and we have a dog, so you may hear the odd barking as well. So it's not something in your house, it's probably something in mine. We're going to start with contractures. It's a big problem. It gets in the way. It starts from tiny, and if you don't look for them properly, you won't find them. The main contractures that any child or adult with SMA can have are, starting in the legs, hips, knees and feet downwards. Feet downwards is called plantar flexion, and these are contractures. The ballet dancers, the toe walkers, the problems, but straight down is not as much of a problem as twisted feet. Those are inverted feet. SMA is a little different from most conditions. Many of the children's feet twist outwards, not inwards, and this is why so many children end up with sprained ankles, because physiotherapists do not understand that these children's feet are different. The hips and knees tend to bend. That's called flexion, and that's because the muscles that flex, pull the hip up and pull the knee backwards, are far stronger than the ones that straighten them. It's as simple as that. The feet are not quite so simple because the feet spend a lot of time hanging down. Even in the small children who aren't sitting, your feet will tend naturally to be in the pointy down position. It's only once you start moving them with toes up, pulling your legs up to reach your toes, or standing, taking weight, that the feet start really coming up. The problem in the upper limbs tends to be more forearms. It's palms down. This is our biggest problem. It's the tendency always to rest with your hand downwards. Now this is natural. If you're sitting in a room with people, they're all sitting palm down. It's the position we work in most. We don't spend a lot of time with our hands palm up, with the palm open, unless you're doing a particular activity. The reason that these hands and forearms get stuck is because the muscle that is strongest is a strange muscle called brachioradialis. It goes from above the elbow to right down to the wrist, and it bends the elbow and turns the hand over. That is much stronger than the biceps muscle, that big one here that men like showing off. That's really not as strong as people think. So it's bend and twist that causes the problems. And the other thing that gets contracted is, of course, the neck and the spine. And scoliosis is just a series of contractures of the spine. Unfortunately, it is very, very hard to stretch because you have the ribs in the way, you have all the tummy contents in the way, you have your pelvis is fixed onto your spine, so it's really not quite that simple as we think to stretch the spine. But it can be done up to a point through activity, through standing, and through exercise. There is one other contracture that we have to consider. Often in the weakest children and some of the adults is contractures of the jaw, meaning that there is limited mouth opening, which can cause problems not only with feeding, but also with needing anesthesia. And it's always useful if you think your child or yourself are getting tightness there, that you try working on it by opening your mouth as far as possible. It does also cause problems at the dentist trying to get that mouth open and get to those back teeth, as well as cleaning them. So what are the main causes of contractures? And the biggest cause of contractures is what we call muscle imbalance. In other words, one muscle is stronger than the other. So that the muscle, as we said, that bends the hip is stronger than the one that straightens the hip. The muscle that bends the knee is stronger than the one that straightens the knee. In the normal situation, we all have muscle imbalance. We know that. We know that our quadriceps, the muscle that straightens the knee, should actually be the stronger muscle, and the one that bends it should be the weaker muscle. And although we all have normal muscle imbalance, the body is still in balance and we don't get contractures. What are we going to do about them? Well, the first thing is we have to find them. And without a good assessment, particularly in the smallest of the children, you won't find them. Everybody knows when hips start getting tight, when you can't get your legs down straight, when you can't get your splints on, when your feet don't fit in your shoes properly. It becomes quite obvious when you can't turn your hand over properly. We can do stretches. Stretches come in different forms. Stretching is not quite as simple as it sounds. It's very easy for a physio to teach you stretches, for you to look at pictures in books or on the internet and think that all you have to do is up, down, foot up, down, knee up, down, head, side, side. It's not that simple. On the other hand, it's not that difficult. If you are sitting for 16 hours a day with your hips flexed, i.e. bent because you're sitting, because you don't stand up, you don't walk, then 5 minutes of stretching is not going to change that. We have to think how we can make stretches last for as long as possible, be as effective as possible, and also when you stop stretching, what will help to control the muscles. If you are stretching your child, or if your carer is stretching you, and you are just lying back and letting it happen, watching an iPad, watching television, that is called passive stretching. It is being done to you. And the only person that is benefiting from passive stretching is the person doing it. The parent, the carer, the spouse, whoever. Muscle will stretch, but it will learn nothing by being acted on passively. It is really, really important that when we're learning and doing stretches, that the person being stretched, the child, the adult, the baby even, is actively involved in the stretch. Now that sounds crazy to say, children and babies, but we make them into games. If you want to stretch the ankle, the tendon at the back of the ankle particularly, you need to get the child, adult, baby, whoever, to pull their foot up actively. We do it through games, we do it through tickling, we do it through holding, we do it through any possible means. If the ankle is tight and it will not come up, it makes no difference. They still need to be working. Imagine pushing a broken down bus. You actually will not move an awful lot, but you will still do a lot of work. This is static muscle work, and it is equally important. We need to always consider that the person being stretched is involved in that stretch. And if you do that, if you make it into games, if you make it into daily life, if you make it as part of routines and play, then you don't have to think, did I do the stretches today? Did I do them effectively? It's active. Think active assisted stretches. And we say assisted because some stretches are incredibly difficult to do by yourself, elbows being a classic one. It's very hard to stretch your own elbows. So a lot of what we're doing is through play and activity. We need to make this fun, interesting, something that is done every day for life. The advent of new treatments is making this even more important. Now we know that there is no suggestion that people with great contractures will not get these drugs. We also know that there are situations where the children are not getting drugs, but we have to consider more drugs are coming along, more children will be treated. We don't want them to think the drugs are going to do everything for us. We won't have contractures once we're on this drug or that drug. It will still happen. These drugs are not cures. They're not going to make movement. And in some cases, some of these drugs are making the contractures worse. And the reason that they're doing that is because they're making some muscles stronger, but not all. We have seen some of our babies on Spinraza with really quite tight hips. And we just have to keep going until we consider whether surgery or other options will help. So there is no let up with contractures. They don't get better by themselves. And unfortunately, as you grow, they will get worse by themselves. Does that mean they stop getting worse in adults? Generally, yes. But constant positioning, poor posture, repetitive movement, doing the same thing over and over can make joints tight. We also know that increasing weakness occurs in adults, and this can add to the possibility of contractures because the joints are not moved through full range. They will not get increasing scoliosis. Once a child has stopped growing between the ages of 16 and 19, the spine is itself fused. You will not get scoliosis once you have stopped growing. There are type 3s who will get scoliosis even when ambulant. That's a whole nother webinar, but it's still something we need to consider. Do not stop stretching. Do not stop thinking they're going to happen until you leave school. So unfortunately, that's where we go. But we have the opposite problem. When you have had a contracture for a long time, over a year, it's going to be incredibly hard to stretch it. In some cases, surgery will work, and in some cases, even surgery will not make the problem better, and if it does, the problem will not go away by itself. Surgery, again, is not a cure. Surgery is a treatment for contractures. We haven't taken away the problem. Weakness, positioning, muscle imbalance. Serial casting is very effective. We know that. SMA is one of the easiest conditions to treat with serial casting. It doesn't work for everybody. It doesn't suit everybody. But generally, the muscles are not very fibrotic, and so there is plenty of stretch in serial casting. And we know this. We have seen it from small results, 5 to 10 degrees over 3 casts to 45 degrees in some cases. So there are lots of possibilities. Splinting is important, but like with everything in life, it has to be comfortable, it has to be acceptable. Night splints shouldn't keep you awake at night. CCDs, contracture control devices, which are all the rage, must be useful. They shouldn't be painful. No splint should be painful. No stretch should be painful. There is something in the body called a pain reaction. You know, if you have pain, you just want to curl up into a little ball. So if you overstretch a joint, you're going to get exactly the opposite situation to the one you want. So instead of straightening the joint, it's going to make it more bent. So pain is not an option. If something hurts, it is wrong. We have another little mechanism in our tendons. There is something in our tendons that tries to prevent them from being overstretched. This is when you see the reflexes. So if somebody bashes your tendon, so you think about the knee, and they hit your tendon, your knee jerks forwards. And that's because it's trying to prevent stretch on the quadriceps tendon. So again, by overstretching tendons, you will get the wrong result. The tendon will try and shorten instead of lengthen. These are things that physiotherapists should know, but many of them unfortunately forget. We get a lot of overstretching, we get a lot of pain, we get a lot of suggestion that by making pain we'll make things better. And that's very often the case with CCDs. If you're going to use a CCD, a contracture control device, it's a device like a splint at the ankle or the knee, and it can be extended. So you can either gradually pull the foot up or gradually straighten the knee. But you must start off in a position of comfort. I cannot, in a webinar, teach you every single stretch. All I can say is that the people working with you should learn to switch off your iPad, switch off the television, get you involved, make it into games for children. You can make it into games for adults if you want. It's possibly a little banal. You may not want to, but if you're not doing the work, you're not gaining anything. Now, I don't know if Andy wants to jump in there with some questions. If there's anything.
We've got lots of questions coming in.
Okay. Let's take some questions then.
Okay, sounds good. Right, we have the first question. How bad do leg contractions have to be to stop standing?
That's very variable. Some people can stand with quite bad contractures, others cannot, for lots of reasons. The first one is asymmetry. If you are standing and you have asymmetrical contractures, that means one foot is tighter than the other, one knee is tighter than the other, one hip is tighter than the other. And ultimately you are standing in a bad position. In other words, your spine is in a bad position, your pelvis is in a bad position. There is no actual value in standing. So it's not always a case of how bad do they have to be to stop standing, but you shouldn't be standing if your spine and pelvis are in a worse position than when you are sitting down. The other thing is it depends on the piece of equipment that you are standing in. Some pieces of equipment, there are supine standers, upright standers, and prone standers. We don't like prone standers. Prone standers are when you are standing at an angle facing forwards, so that ultimately there is a lot of strain on the neck to come up. We don't believe it is good in neuromuscular conditions. It does not put weight through the feet, so it's not helping bones. It's very much used in cerebral palsy. It's not good for the spine either. We prefer upright or supine standers. Now, a supine stander is one where you're lying on your back. It's what we call a tilt table, and it comes up to standing, and it doesn't have to come the whole way. Now, you can actually have quite bad contractures and still use a supine stander because they are very supportive and they do help you come up. Some of the wheelchairs that come to standing will straighten you out first like a supine stander and then bring you up. Some push you straight up from sitting, and that makes it much harder. The other thing is it's actually quite uncomfortable when you have tight knees and hips because all the pressure ends up being taken through your knees. So comfort is a big issue when you have contractures, but the decision to stop standing is actually with the individual. There are some people who will continue standing really with quite bad contractures and some who will stop with relatively minor. It's usually an individual decision.
Okay, great. You'll have to forgive me because when I was a lad, half of this equipment didn't exist, so I might get some of the pronunciations wrong. My son's physio put him in a stander with straps around knees, but no CAFOS or gaiters or additional support, and he cries in pain and refuses to stand. Is this right?
Firstly, like we said, pain is not an option. It's not a good idea. Secondly, straps should never go over the knees. Straps should go below or above. There should never be pressure on the knees through straps. Now, we know that many of the standers have knee blocks, but the actual support of a knee block should be literally just below the knee, so that it's pushing at the top of the tibia, not over the kneecap or knee joint. It should never be causing pressure on the kneecap. This is really, really a bad way to stand. So that CAFOs and gaiters are not essential in a standing frame, but certainly the pressure has to be in the right place. Many people will manage standing frames without CAFOs or gaiters. Gaiters are not expensive. But the problem is, if you have contractures, then basic gaiters will not help because they're straight. The metal bars in basic gaiters cannot be adjusted to consider any knee flexion contracture. So gaiters as such will not work to help. There are some knee immobilizers that can be angled, like the CCDs. They have knee locks at the sides and they can be angled up to 30 degrees, and they may be more useful, but they're obviously much more expensive. And there is some issue in some places where therapists don't want to get this sort of equipment, where they believe that once you're in a frame, that should be enough. It's not. The other thing the therapist could do is actually make soft cast splints. These are extremely easy to make. They're very comfortable and they do help. So that it could be suggested that soft cast knee splints would make standing much more comfortable.
Okay. Right, next question. My son's hip contractures are terrible. Is there an op for this?
There is an op for hip flexion contractures, and you can guarantee, unless you have literally 24-hour management for the first few months, you are constantly considering standing, prone, lying, wedging, that they will be back again in a year. They do not last. If you think about it, you're sitting all day, your muscles will, even if they're cut, they will join back again. You don't remove muscle, you don't take it away. As we said, it's a treatment, not a cure. You have to accept with hip flexion contractures, if they're really interfering with movement, with function, if you're worried that the effect of drugs will be less, and we are thinking about this ourselves at the moment because many of our little e type 1s are getting quite tight hips, how are we going to manage this, particularly as they grow? Will it stop the effect of drugs being positive? But releasing hips is not a big operation. It's not a comfortable operation. It's not a big operation, but you need to think, how am I going to prevent them? You need to be standing 3-4 hours a day, not all at once, split into different things. The child or whoever it is needs to spend some time in what we call prone lying, a good tummy position. They will need wedging when they're lying on their back to make sure that they're not just bending their hips and knees. The other problem with hip surgery, if you have knee contractures as well, what you have to consider is that it's very difficult just to straighten hips, because if the knees are bent, the hips are automatically bent in many positions. So it is possible, but it should not be done without a very, very good program in place afterwards to manage that and keep it as good as possible for as long as possible.
Okay, and follow-up question to that, I'm guessing that if a child gets to adulthood and their contractures aren't too bad at adulthood, are they going to maintain the same, or do they still need the same amount of working?
Generally, they will remain pretty much the same in adulthood, but one of the problems we have with adults, as everybody knows, is that when you get to somewhere between 16 and 19, everything stops. Physio stops, hydro stops, activities stop, whether you go to university, whether you go to work, whether you work from home, whether you don't, activity stops when you become an adult. There is no NHS physio unless you fall out of your wheelchair or get a chest infection or have some sort of pain. And this is a big problem. We need to keep our joints mobile. And one of the things we know about some of the adults is they do deteriorate. They get weaker. And as they get weaker, again, you will get muscle imbalance that will change. And if that happens, yes, your contractures, not your spine, but your contractures can get worse.
Okay, interesting. Thank you. Right, next question we have. My daughter's head turns well towards the controls of her chair, but stiff the other way. What can she do? She does not have rods.
Neck tightness is a big, big problem. It is something we work on from the beginning. We assess the neck from tiny, and we need to work on necks because it can affect many things and not only wheelchair controls. One of the problems is this person says their child does not have rods. But if the neck is tipped now and the child subsequently has rods, the neck will get worse. We need to stretch. And again, this is active turning side to side. There are 3 groups of movements in the head and neck that need to be done regularly. Side to side. Ear to shoulder, and backwards and forwards. Again, with small children, we can make it into games. We can use push-pull. There's a technique called PNF, proprioceptive neuromuscular facilitation. Don't remember that. PNF, really nice for heads. We do a lot of work with it. Even pushing back into a pillow or the headrest of the wheelchair, pushing sideways. Again, it has to be active to gain range. It's not impossible. We have managed to stabilize necks. We've managed to improve neck range, but it takes work from both people.
Okay, great. So we've got another question. Will Spinraza make contractures worse? This is
not
a
for
very
everyone.
common question as well.
It's the problem is every child is different. We don't know the effects on adult contractures, but we know that if it changes muscle imbalance, yes, the contractures can get worse, but it hasn't happened in everyone. The problem we see with Spinraza is that even though we're seeing over 30 children at Great Ormond Street on Spinraza, They are all doing something different. They haven't all got the same movement. So some are stronger in the arms, some are stronger in the legs, some are stronger on one side than the other. So it's very difficult to predict what Spinraza will do. We have to work hard for Spinraza. We need to exercise, but we also need to think about those contractures. So again, regular assessment is vital, and every child on Spinraza should be getting at least 6 monthly assessment. We try and see every child when they come in for injection, which gives us an extra opportunity to know what's going on. But we need those children well assessed, well reviewed, and any changes need to be worked on.
And I assume if there is a situation where contractures worsen, families will be shown how to manage that as part of their treatment?
Absolutely. I mean, like with anything, the most difficulty we're seeing is actually with hip flexion contractures, where we have several children whose hip flexion contractures have got worse. But then similarly, we have several children who have not got worse in their hip flexion contractures, who are standing beautifully, who are standing in CAFOs, who are really doing very well. And now that we have the 2s and 3s also having Spinraza, we will equally have to keep an eye on all of them, all of the 2s, to see what they're doing with their hips, knees, forearms, everything, including necks.
Okay, great. Good question. Can you ever stretch too much?
Yes, absolutely, for 2 reasons. Firstly, because the muscles will fatigue. They can only take so much work, and also everybody else will fatigue and get bored and not want to do it ever again. There is an optimum amount of stretching. There is no recommended minimum. Ideally, you will do at least 1 set of active assisted exercises to all the tight joints throughout the day. So it doesn't have to be in 1 session. You may do some over the edge of the bed in the morning. You may do a different one during the day. You may do, for some of the ambulant children, you may build them into teeth cleaning. We do our stretches with teeth cleaning. There's many different ways of building it up over the day. But importantly, splinting, standing, positioning, add to the efficacy of stretching. It's not just about stretching. It's about position. It's about standing. All the little E's. Every single infant and child who's got head control, who is not too contracted, should be standing. But head control is the key. In the very weakest, it's very difficult to stand apart from in a supine stander. But standing definitely helps reduce the rate of contractures. CAFOs, I know CAFOs are not popular. We give out CAFOs to almost all of our type 2s. Why do we do it? Because we believe it helps with the ankle, knee and hip contractures. Apart from helping the spine, the mobility, the balance, the exercise, you name it, we like it. But we know that not only do many centres not like it, they don't have the good orthotic management that we have that allow us to put all our type 2s on non-ambulant type 3s, and even now some of our better ones are in CAFOs.
Okay, thank you. Now there is treatment available. Will tendon cutting be approved more often?
We're not sure, because what you have to think of is why do you want to do it? Tendon cutting is never taken lightly. It's a decision that professionals will discuss very much with the family, if possible with the child, adult, whatever, but you have to think why you're doing it. Is it going to improve function? Is it going to improve life generally? Is it purely for cosmesis? Do you want to get nice shoes on? It's perfectly acceptable if you have very twisted feet to want surgery just for your feet to look better, to get nice shoes on. On the other hand, if you want your hips released and you're just going to sit in the same position again in a chair for most of the day and not do anything, you're not going to be active. You're not going to use it to roll because somebody turns you. You've got to think, why do I want it released? We would like to think that these drug treatments would reduce the need for surgery. We don't know. Again, it's very individual. We can recommend surgery and the children don't want it, or the families don't want it. In adults, surgery is rarely seen, although I do know several young adults who would like their hips released to make life easier for spouses, for partners, and just generally for their own benefit. Some very active borderline type 2-3s would find having less hip contractures makes them more independent. So we have to again think on an individual basis whether the drugs themselves will make surgery more. There is one situation we have to consider. It has been said for the last 30 years I have been doing these children that hip surgery for dislocated hips was a waste of time. The hips would fall out again. We now have to consider those borderline type 2 and type 3 children. If their hips are dislocating and they're going to walk with these new drugs, do we need to do more hip surgery? We don't know yet. We would not put any child through surgery unnecessarily. It is big surgery. But we have to consider that if our good type 2s are going to start walking, it's going to be a lot easier if their hips are in joint. So again, we have to think from tiny. If you have a child of 18 months, we have to think now, are they going to need their hips done? Similarly, we have a young man on Spinraza who's borderline 1-2. The parent said, can we put his hips back in? We still do not think he will walk independently, and parents agree. So the answer is no, it is of no value.
Okay, interesting. Right, we've got another question. I've heard this question a couple of times actually, about jaws and jaw opening. So the question is, jaw opening is a problem for my son and now affects eating and chewing. Any advice?
It's quite difficult because there is no simple surgery that would release this. It is becoming a problem for some people. There is a piece of equipment called a TheraBite, T-H-E-R-A-B-I-T-E, TheraBite. It looks like a pair of tongs that goes in the mouth, and as you open the tongs, it forces the mouth open. It can be done quite gently. It can be useful in some cases. It's not an expensive piece of equipment. It is used more extensively in Scandinavia quite regularly. It can probably be accessed through either a speech therapist. Speech therapists do tend to know about it. It is something you need to discuss with a speech therapist, but there is something available. Again, working on that jaw will help, but the jaw is a complex structure. It's not as easy. So it really would be helpful if it was done in conjunction with a good speech therapist.
Okay, and just as a follow-up to that, so I myself have had issues with my jaw in the past. Is it possible for jaw issues with SMA to cause things like headaches?
That's a sort of mechanical headache, and that will be quite difficult to know. There are specialist maxillofacial physiotherapists, maxillofacial teams who would know whether there are nerves being impinged that would cause headaches. But actually, for the jaw itself, I am not sure because my anatomy of the head and brain is not good enough to know whether the nerves that open the mouth would actually cause headaches. And actually, again, the best people to ask would be a speech therapist because their knowledge of the head, the brain, and the nerves around the face, mouth, jaw is best in speech therapists.
Okay, cool. Right, another question. What's the best things to wear at night to help prevent leg contractures that is reasonable for a child to sleep in?
It really depends where the contractures are. we use what we call soft cast knees if the knees are a problem. You can wear soft cast knees and ankle splints together, or you can alternate. So one foot has an ankle splint and the opposite knee has a knee splint. If we can keep the knees down at night, it will help to keep the hip flexion contractures down as well. Soft casts are literally what they sound like. They're like a relatively rubbery form of fiberglass. Soft cast is quite easy to use. It takes us about 20 minutes at Great Ormond Street to make a pair of soft cast splints that are ready to take home with the child. And they come in pretty colours, which is great. But they literally can be padded, they can be comfortable, they shouldn't be painful, and they're very, very easy to wear. Now, that's not saying that everybody is going to provide soft cast splints. We actually make them. Gaiters, as I say, will only be comfortable if the knees are straight and you're trying to keep them straight. If there are knee flexion contractures, using gaiters will actually be quite uncomfortable. There is no way that you will make it comfortable with contractures. And the same with feet. AFOs are fine if they're comfortable. Many children complain they're not comfortable. We cannot tell any child it does not hurt. You will get used to it. If they're rubbing, if they give them cramp, if it means that it's harder to turn over, if it adds to the weight of the limb so that they find it harder to move, it's understandable they don't want to wear them. Often we'll try and find alternatives. Even 2 hours of splints at night in bed is better than nothing. So sometimes parents will put them on at night and then take them off later, or we can wear them in the evening. I'm not convinced it's quite as effective. Or we can alternate 1 foot one night, 1 foot the next, alternate feet and knees. I think you need to work together with your therapist to find the best solution, but a sleepless night is not just a bad thing for a child, it's a bad thing for a parent too. It's very, very difficult for a parent to function during the day when they've had a sleepless night, and very hard for a child to function at school when they have also had a sleepless night. Life shouldn't be a battle. It's hard enough with all the things we have to accept in SMA, all the things that parents have to go through. We do not need, as physios, to add more battles. We've got to make this as good as possible. If the child can't sleep, we've got to find alternatives. I'm not 100% convinced that sleep systems are the answers, but some children do get on very well with sleep systems. Many children with SMA find them too hot. If the child wants turning at night in bed, it can make turning really difficult because then the whole sleep system has to be changed. So that's not much fun for parents who are getting up to turn children at night in bed. But again, there are alternatives. There are alternatives to sleep systems that are actually much easier to use than sleep systems. There are things called E-rolls, T-rolls, all sorts of things that can help to position the child at night in bed. So the issue is finding the right solution for each family and child.
Okay, great. We have a question. This is an adult related question. Will contractures on adults cause more discomfort if strength is gained through treatments?
There is no evidence to suggest that any power gained through treatment will pull on the contractures to make them uncomfortable.
Okay.
The question has to be, what effect will the power have? And ultimately, if you have a contracture, that muscle is already tight and short. So it's unlikely that the pull of the muscle will be considerable to make the contracture uncomfortable. What the biggest effect will be that you will have the power but no movement. So that if you have a severe knee contracture and you get more power in your quadriceps, but there is no ability to straighten your knee, then that power up to a point may be wasted. You can still do static work. We don't know whether any contractures can be reversed. It's unlikely, but we still have to see that. The problem about contractures is if you think about a joint, it's not just about the muscles. Joints have layers. Sound a bit like Shrek. Joints have layers. They're not onions, but they have layers. Around a joint is a very fibrous structure that can also contract. You have ligaments that have shortened. You have tendons. You have muscles. You have skin. People forget this. Your skin is different. If you aren't bending and stretching, your skin isn't bending and stretching. So it's more than just thinking about what the muscles are doing. There's an awful lot to consider with contractures that is not just about what the muscle is up to. But it doesn't mean you can't exercise the muscle. You just may not get the amount of movement back that you're hoping.
Okay, great, thank you. A few more questions. Popular topic, contractures. Are there standing frames for adults or standing slings made for adults?
Very much so. In fact, I worked at Stoke Mandeville, the spinal injuries unit, before I ever came to paediatrics, and we had several standing frames for people with spinal injuries. So there are many types of standing frame. The problem is not the standing frame. The problem is getting into the standing frame. And what you need is a standing frame with a sling system that will get you into standing, because actually it's incredibly difficult to get from wheelchair to standing frame. The alternative is standing wheelchairs. They are incredibly expensive. You're talking between 20 and 25,000 pounds, the cost of 3 small cars. They are not insubstantial. They are extremely heavy because they have to be stable. So a lot to consider if you want a standing wheelchair. But the most important thing about adult standing frames is you have to think about how you're getting into it, because carers will find it very, very difficult to get an adult into a standing frame without assistance. And that's the main thing. But there are many of them on the market. For people who are unaware, there is an exhibition 2 or 3 times a year called NAIDEX, the National AIDS for the Disabled exhibition. It's not called that anymore, it's just NAIDEX. There's a Northern NAIDEX, there's usually in Manchester, there's a Scottish NAIDEX, and there's an NAIDEX at the NEC in Birmingham. And if you want to look at these pieces of equipment, that is a very good place to go because they're often on display at these exhibitions. The other place to go for information is the DLF, the Disabled Living Foundation. It used to be government funded and it was in every major city. Like with so many of these things, government pulled the funding and it is now a central agency based in London, and it is a charity. But they have the biggest source of unbiased, straightforward information on any piece of equipment. dlf.org.uk. They will give you any information they can on the pieces of equipment that you want. But the most important thing is they have no axe to grind. They're not selling anything. And so they will give you the best unbiased information.
Okay, brilliant. Right, another question. My son is 9 months old with SMA type 1. He is unable to turn his palms towards his hands. What can I do to help him to turn palms of his hands when he goes to his mouth?
I think the important thing is to do it passively to start with, but do it often and do it in play. You may find if they're allowed any food that they don't have to take everything through gastrostomy or NJ tube that they are taking. You can put little bits of cream or flavors or even a teeny bit of melted chocolate onto the palm and bring it up to their mouth. Show them what you're trying to do. 9 months is a great time to start. They might not be able to do it actively, but do it over and over, clapping hands together, anything where you're bringing hands together in games, in the bath, splashing in the water, bringing the hands, turning the hands over, in any situation. Games, activities, hands to mouth, all need to be done. You can put hands on your cheeks. You just have to make it into games and get them to understand what you're trying to do. Look at your hand, look at the chocolate, look at the cream, look at your fingers. All sorts of things you can be doing with those hands. A great time to start 9 months.
Must admit, I do most things for melted chocolate as well. So, right, next question. How can I stop toes overlapping?
You can't. It's quite a normal thing. Unfortunately, unless they're causing problems, it's something, you know, the normal population, there are plenty of people who have overlapping toes. If you are really, really concerned about it, you can ask your GP to send you to a podiatrist. Now, whether this is an adult or a child, a podiatrist, the people who used to be called chiropodists, you will find plenty of them for adults. They are a major rarity for children. Major, major rarity for children. But those are the people you need to discuss them with. There are toe spacers. There are many different things. They do make, sometimes toe spacers can make it harder to get shoes on because then they all fall out or get stuck in the wrong place, or even putting socks on can be more difficult with toe spacers. But if it's really causing a problem, then a podiatrist is the place to go. There are very few orthotic companies, the companies that make splints, that will do anything for toes.
Okay, excellent. We've still got more questions coming in.
Fine.
Back to the person.
Okay.
Back to the person that mentioned about the jaw difficulties. They've said that my son needs a tooth out, but the anaesthetists are refusing to do so. It's very problematic, they say. They have a terabyte maxi. They have a terabyte. Maxi consultant won't consider surgery.
Then I suggest you speak to your neuromuscular consultant, because very often the hospitals that have a neuromuscular service will also have a maxillofacial and dental service that should be able to help. A bog standard dentist or a dental service in a general hospital may be worried about it, but certainly a maxillofacial department in a children's hospital or neuromuscular service will have much more experience of children with jaw opening problems. So that's where you need to go. Your neuromuscular consultant, your neuromuscular clinical nurse specialist should be able to point you in the right direction. You will probably need a referral from your neuromuscular consultant if it's at the neuromuscular service.
Okay, cool. And sorry, just another follow-up question to that.
Fine.
Would surgery on the TMJ, the muscles along the side of the face?
Again, that's a maxillofacial issue. It's extremely rare. It's extremely rare to have that sort of surgery, but you need referral to what they call MaxFax, maxillofacial team, usually at specialist hospitals, usually at specialist children's hospital. It is, or a dental hospital. Somewhere like the Eastman Dental in London would have a MaxFax team, but it is a very, very specialist thing. It's not a dentist. It's not even an orodontist. It is maxillofacial, and they need to go to that sort of surgeon.
Okay, awesome. What are the signs of a contracture?
That the joint does not move through full range. So you've got to know what full range is. You've got to know what normal is. If you don't know what normal is, look at yourself. There are 3 problems with knowing what a contracture is. Firstly, knowing where to look for them. Because very often, if you don't think about turning hands fully upwards, you won't look for them. In teeny weenies, people don't look for hip flexion contractures, but we have 4, 5, and 6-month-olds with hip flexion contractures. So they can be there from tiny. So the first thing is looking for them. The second thing is knowing what is normal. And if you don't know what's normal, look at yourself. And if you're not normal, look at someone else. And the third thing is hypermobility. Many children with SMA have too much movement, but not at every joint. We know that a lot of the fingers and thumbs are overbendy, and that also causes problems. Some of the hips go every which way. They have no contractures, but they have no sensible ranges either. The hamstrings are not to be stretched. Nobody seems to know what a normal hamstring is. Don't worry about the hamstring range in an SMA. It's not going to cause problems. This is not cerebral palsy. Feet should come past 90 degrees so that ultimately your toes should come 20 degrees past the line of your ankle. So your foot should come 20 degrees towards your shin from neutral. Shoulders go everywhere. It's very rare to get shoulder contractures. Elbows should go straight. Many of them go over straight. We have a lot of SMA children with hypermobility at the elbows. We have a lot of children who over straighten at the knees as well. So we need to be careful when we're stretching the feet that we're not just putting the stretch onto the knees and making the knees more over straight. So again, you may need some help from your physiotherapist, but if your physio, again, is not looking correctly, she won't find them. Let's go back to hamstrings. Hamstrings run from the bone in your bum, and you do have one. You're sitting on it. If you're sitting down at the moment, you do have a bone in your bottom that go all the way from there. That's where they attach to the back of your knee, below the knee. So it's a very long muscle, and it can get tight. It is brilliant if it gets tight because it can be the only muscle that is stabilizing your knee and your hip. If somebody says to you they have got tight hamstrings, you need to know one simple question. Somebody says to me that a child has tight hamstrings, the first thing I want to know is how old is that child? Because a baby, as we know, in the normal situation, can usually get their feet way over the back of their head, sometimes around their neck, and they have naturally very long hamstrings because that's how they are in the womb. As you get older, your hamstrings get tighter and tighter. That is natural development, and it is not normal for an adult to be able to touch their toes in standing. Now, that's a surprise to many people listening. It is one of my favorite things to do in a conference or lecture situation is ask people to touch their toes. Because if you can touch your toes, like I can easily, you actually have long hamstrings and they are less effective than short ones. So knowing what is normal hamstrings is really important, because I only wish every physiotherapist in the country knew to stop stretching the darn things in neuromuscular conditions, because it really is most unhelpful.
Interesting. But your conferences are fun with everybody bending down and touching their toes.
My feeling is I'm not here to do all the work. If I'm doing it, they have to work too, because otherwise they don't remember anything. Half of them are asleep. And they usually give me the graveyard slot, last thing in the afternoon when everybody's had enough.
Superb. So we've still got questions coming in.
It's fine.
So
if you have to leave exercise till next time, we'll leave it.
Yeah, no, that's absolutely fine. What is your opinion of standing slings being used with ceiling track hoists as an alternative to or in addition to a standing frame?
If you can achieve a good position, if the person is comfortable, and if they're actually weight bearing, and this is important, standing is weight bearing. If you are suspended in the sling with your knees and hips flying around in midair, you are not standing, you are suspended. And that might be great fun and it may feel wonderful, but it's not standing. Standing is about weight bearing. The beauty of standing slings is you can actually often walk in them. And the beauty of walking, surprisingly enough, is that it is actually better for your bone health than static standing. In other words, standing still. The endocrine studies, particularly several that have come out of Australia, suggest that the vibration that is caused through the bone by taking a step is what improves bone density and bone health. And that is why so many places now are using vibrating plates for standing on, because it is felt that the vibration is what is useful. That doesn't mean to say that doing exercise on vibration plates will necessarily make the exercise better or more effective, but certainly static standing on vibrating plates is thought to improve bone health. It also makes you want to wee more, and it has lots of other effects, but that's besides the point. But it's standing weight bearing that actually helps the joints, the spine, and everything else. Dangling in a standing sling is not helpful. Well, it might be lovely, but it's not having the desired effect.
Okay, brilliant, thank you. Another question, why do some children with SMA type 3 walk on their toes?
Weakness. It's as simple as that. It's purely mechanical. And strangely enough, it's the same in muscular dystrophy. It's all to do with the mechanics. I really need one of those little artist's dolls or something. The top and bottom of it is your muscles that are weakest are your gluteus maximus, your bum. What does your bum muscle do? And this is why women have bigger butts than men. Your bottom muscle is basically the one that bends down and picks things up off the floor. It's the one that helps straighten you up when you're getting up off the floor, up off a chair, up the stairs. So you can see exactly now why women have bigger butts, because they do more picking stuff up off the floor and running up and down the stairs. That is the first one that's weak. This is what leads to hip flexion contractures. This is the strongest muscle in the body. It's short. So we don't want long hamstrings. We don't want a long gluteus maximus. It is a short, tight little butt muscle. It works really hard at keeping your trunk straight on your pelvis and your legs in line. So it's got a lot of work to do. That's the first one that's weak. The second one that's weak is your quadriceps, the muscle that straightens your knee. So basically the two muscles that hold you up, get you up off the floor, upstairs, off a chair. So that when children are struggling before they're diagnosed, those are the three classic things that parents say apart from running. They have struggle getting up the stairs, they struggle getting off the floor, they struggle getting off a chair. Jumping, running, we know those as well. So the mechanical effect of that is the hamstring is the thing that works. The hamstring that we don't want long, we want short. I can't say that enough times. The hamstring is working as a hip extensor and a knee extensor. So basically the hamstring is working instead of the gluteus maximus that straightens the pelvis, and instead of the knees, which the quadriceps, which straightens the knee. But the hamstring works most effectively as a hip and knee extensor when another muscle called gastrocnemius is working with it. Now, gastrocnemius is your biggest calf muscle, and that's the one that pulls you up onto your toes. So when the children are tired, particularly when they're weak, when they're doing a lot of falling, they will walk on their toes because it actually stabilizes their hips and their knees. It is not useful to tell them to walk with their heels down because they will fall more. And actually you're making life more difficult for them. What we need is them to be able to stand still with their heels down. We don't expect them to walk with their heels down. If you need to walk on your toes, you need to walk on your toes. They don't do it for fun. They do it because they are more stable and it is more effective than walking with their heels down. So don't chastise a child that is walking on their toes, but do make sure they keep the range of movement at the ankles for things like getting up from the floor and chairs where you need that range. That's the important thing. They need to walk on their toes. They need to walk on their toes.
Okay, excellent. Right, another question. I know you touched on hip surgery. Are you thinking it's fairly black and white as to whether it's done for now, as is wouldn't
Nothing is ever black and white. If life was that simple, the health service would have a much, much easier job.
And they go on and say, or do you think that it's something that needs a whole discussion all of its own?
Oh, absolutely. We desperately, desperately need to have consensus on hips. But we also need to agree that not every child will fall into the same little basket. We know that SMA is a spectrum from the weakest to the strongest. Every situation is different. Every family is different. Every need is different. Hip surgery will have to be done on a child by child basis for the best interest of that particular child. There is never going to be a black and white. There's never going to be a right and wrong. And ultimately, parents particularly, this is under 18-year-olds who are not allowed to make their own sign on the dotted line. It is very, very hard to put your child through surgery for lots of reasons. The first one is we know that with every anesthetic there is a risk. That is not just SMA, that is every single person in the world. There is a risk of having an anesthetic. It's not big surgery if it is just a release of the flexor tendons at the front. But bony surgery is always going to take longer. So if we have to go in and do hips, actually putting hips back in joint, changing the shape of hip joints, changing the shape of the top of the femur where the ball of the ball and socket joint is, of course it's going to take longer. The longer the surgery, the longer the anesthetic risk. The longer the recovery, both from terms of physical management and respiratory management. So that is an issue. It is not an easy decision. I think people have the idea that all surgeons want to do is chop, chop, chop. And there are surgeons like that. That is undoubtedly true. We are very lucky that we have worked with some amazing orthopedic surgeons at Great Ormond Street, and we talk together. One of the nicest things about our clinic is we're all in there together. Doctors, neuromuscular team, orthopedic team, we are in the room together with the patient and child discussing it all together, and that is such a bonus because very often if you go to an orthopedic surgeon, nobody ever finds out what they've said. They're not always the best communicators in the world. They'll just say, yes, we can do this, this, and this. I'll put you on the list. And that's very difficult for parents. The other person that is in clinic with us is the orthopedic nurse specialist, not just the neuromuscular nurse specialist. Because what you want to know is more information about the orthopedic surgery. Are they going to be in plaster? Are they going to be in pain? What happens afterwards? How long will they be in hospital? What happens when they're in hospital? What if I need a different wheelchair? All the questions the orthopedic nurse specialist can answer. The occupational therapists are around on the orthopedic team to make sure wheelchairs are correct. So you need to make sure that the whole team is talking. Everybody's talking to everybody else. It is so important for parents to get all the information. It's never, ever small to put your own child through surgery. It's really, really difficult thing to do. And we would take every child as an individual. There is no black and white. It's what works for each family, each child, each situation.
Great, thank you. And I think at the moment we have one more question, and that is, how can I stop a weak type 3A child stop turning her foot in when she walks with the frame? She's very unsteady and takes most of weight on with locked arms.
That is weakness. It's as simple as that. That is weakness and instability. We do use, sorry, there's an enormous amount of fireworks going off at the moment. We use something called a tri-lock splint, and we have found it very successful in SMA3. A lot of the children like them. And in fact, possibly it was even some of the SMA3s that introduced them to us. Tri-lock splint is a flexible splint. It's exactly what it says. It is 3 elastic straps, so that you have a neoprene, a fairly rigid neoprene medial piece on the inside of the ankle to prevent that twisting, and then 3 elastic straps holding the foot and ankle in position. It's a nice splint for 2 reasons. Firstly, it tends to be extremely comfortable, And the second thing is it goes into a normal size shoe, which is very, very important. It's also very discreet, which a lot of the kids like. But it is a very, very good splint to try in that foot twisting situation. It gives stability and mobility, which is often what the foot needs. If that is not enough, you may have to go to something called a SMAFO, which is a more rigid plastic ankle splint. But it definitely sounds as though that young lady, I think you said a lady, that whoever, that child needs some sort of foot orthosis to control that and take the pressure off the arms and redistribute the weight properly.
Great stuff. But one more other question that's come in, and just on the back of the last question, someone else has said in the chat room that yes, my daughter used this and it was very helpful. So just some useful feedback from someone else.
So that was a Trilock splint.
Yeah, that's right.
Yeah, no. We have several of our type 3s in Trilock splints, our ambulant type 3s, and some of our other ambulant children who twist.
Excellent. And we've just got one more question come in after me.
They're also available on Amazon.
It is, what causes tremors in SMA type 3?
No idea. Don't think anybody does. And it's not only a problem of type 3, they just seem to be more obvious in type 3. They're actually almost diagnostic. The type 2s get tongue tremor as well as hand tremor. It's just more obvious in type 3, but it's there in type 1 and type 2 as well. Strangely enough, although the heart is not affected in SMA, there is a tremor on the ECG as well. Apparently it's there if the baby's crying, but you can see a tremor on ECG. You can see a tremor in the tongue, which is typical of SMA. The problem we have with type 3 SMA is that many things can make it worse, and one of them is salbutamol. And the biggest problem is that the type 3s do not like the tremor getting worse because it can interfere with hand function. It also doesn't look very good if you're shaking. The kids can get quite worried about it because they don't think it's something that their friends actually react positively to. But I don't honestly think that anyone knows what the tremor is from in SMA.
Okay, great. So there's lots of people in the chat room saying thanks and yeah, brilliant information, and we've learned a lot, etc. Obviously I can't go through all the thank you messages.
No, it's not the issue. The issue is, do we want to continue or do we want to leave exercise for another time? It's probably enough for one evening.
You think so? It's entirely up to you.
No, I think we should give it a rest. I think if people want to talk more about contractures, I'm happy to take more questions. If people want more advice, if they want specific advice on particular stretches and exercises and activities, if they want to look at how we do back stretches, particularly with littlies, we do them over therapy balls and peanuts. We can do back and neck stretches. We can do them through swimming. When you're in hydro, you can have stretches. You can add stretches to many things. One of the reasons we like horse riding is because we feel it stretches the back and neck. But we really do think that as long as you can get into a routine of stretches, active stretches, it becomes much easier. It needs to be done daily. It's a real pain in the butt, but it is important. We can't always prevent contractures, but we can do our darndest to try and make them get worse slowly.
No, that's fair enough. While you've been talking, there's been another couple of questions coming
No,
about
fine.
contractures. Okay, so we've got a question. What are the best exercises for a type 3 child to do to give her the best possible chance of standing stroke walking again? She's not currently eligible for Spinraza.
Oh, my biggest bugbear in the whole world. I truly, truly believe that many of the 3s could get back on their feet with Spinraza, some of the smaller children. I think the first thing is lots and lots of standing. Let's keep them straight because they won't start walking again if they're very contracted. So standing in whatever way. Swimming, lots of swimming. We need to be aware that the contractures, hips, knees and feet, the muscles that we need to work are the ones that straighten the hips, i.e. the butt muscle, the ones that straighten the knee, the quadriceps, the ones that pull the foot up. So that your physio and yourself, you should think, what will make my butt straighter? What will kick my foot forwards? We use a lot of TheraBand, a lot of TheraBand. It's not that exciting, but again, you have to make it into games. A lot of activities for knees, lots and lots of fun games and activities. You can do things where you're picking up objects off the floor and putting them into a bowl. Anything you can think of that will straighten those knees. Anything on your side where you're opening your knees, what we call crocodiles. That's a really good exercise for the hips, is lifting that leg up. You can lift your leg up and somebody, a brother, sister, cat, dog, jump through it, throw things through it, make it into games, make it into fun. Kicking games, anything where you have skittles, targets, the cat, I don't know, whatever you want to use, but those you have to think, what muscles? Those are the muscle groups I want to work. The ones I don't want to work are my hip flexors, the ones that bend my hip, my knee flexors, the ones that bend my knees, and my plantar flexors, the ones that point my toes down, are the ones I want to avoid working. So I want to work those that straighten the hip, but also the ones that lift the hip up sideways. So a lot of work in side lying. So I say crocodiles, clams, anything like that. You can use TheraBand. You can sit and squeeze chair legs in and out. There's all sorts of things you can do that can be done while you're playing with an iPad or watching television.
Great. And just take note, everybody, please do not try kicking your cat at home.
No.
Next question. My son is 4. He has type 1 SMA, been on Spinraza since 18 months. Any advice for him starting school?
In terms of management, it's quite difficult because, again, the first thing is we need an EHCP in place. And the EHCP has got to be quite specific about what they need. Ideally, it's very hard to say they're 4 and a type 1 because there is, again, a spectrum. I don't know whether they're doing any standing. If they're standing currently before they go to school, you want them standing in school. If they're good enough to be standing in orthotics, then they need to stand in orthotics in school. They need, first and foremost, to join in with the school day. We have to think how physio fits in with the classroom, how it fits in with life. What many, many people forget with physio and Spinraza, while we're talking about lots and lots of standing, there is hands and arms and lots of work to do with the hands and arms as well. Things like scissors are almost impossible for kids with SMA. Tearing a piece of paper, all these things we need to practice, that we're looking at, we're reassessing what we're thinking about in neuromuscular. Hand function, how tight can we squeeze, how can we pinch, how can we do things with our thumbs, because power, hands, bringing our hands together, lifting our arms up, all the things we still need in the classroom. So it's not just about standing, but it's where it fits in as well. Obviously, mobility is important. Are they in an electric wheelchair? Can they get an electric wheelchair? How well can they interact around the school? How well are they being integrated into games, activities, floor time? If they're sitting in a chair when everybody else is sitting on the floor, what's somebody going to do about it? How can they make that child feel exactly the same as everybody else? Where are the stumbling blocks? How we're going to get rid of them? How can we physically keep that child as active as possible in the classroom? Kids get up and wander around. This is the beauty of ever watching an infant class. They get up and wander. Children don't stay still. You can't say sit down and stay still. They don't. They wander. They love doing things. They love being active. Children are moving creatures. This is why most children hate school. Children are moving creatures. They want to move around. Adults get up and wander around when they've had enough. You're sitting at a computer all day, you'll get up and make a cup of coffee. You'll get up and do something else. You'll get up and look out the window. Children are being forced to sit all day, every day, in a wheelchair, in a special chair, as though they don't ever move. Children are first and foremost moving animals, and we want to keep them active, moving, mobile, and that includes in school.
Great. Okay. Yes, there are another couple of questions coming. I think for anybody that hasn't asked a question now, then please email your questions to Lucy, and we'll ask the questions after the event, if that's okay. So we've got 3 more questions. Are there specifically trained local specialists that deal with contractures, or a name for them, as my physio knows nothing?
Then your physio needs to go and visit a physiotherapy service that does know something. So she needs to go and spend some time at her local neuromuscular service, or there are usually courses. There are pediatric physio groups dedicated to neuromuscular conditions. There are courses all the time in neuromuscular. We run courses every year. They should make the effort to go and find out. These children, yes, they're rare disorders, but they are becoming more common. More and more people are seeing them. The children are around. If your physio doesn't know, then she needs to get off her butt and find out.
That sounds like good advice. My son is right-handed, but now is unable to use left arm, and fingers are now curled into palm. Is there anything I can do about this? I hope he will eventually get Spinraza, and would like to keep him as flexible as possible.
Absolutely. 2 things they can do, physio and OT. OT is almost impossible, if not very difficult to get hold of. They should be being splinted. They should be being stimulated. Lots of different textures. We've used taping. Now, I am not advocating taping for every single child, but we have used taping a lot in SMA hands at GOS, and we're finding lovely, lovely results with therapeutic taping. So if you've got a good taping person near you who knows anything about pediatric taping, it really has been quite effective in hands, and it's something that we're doing a lot. Splinting, but good splinting that doesn't get in the way, splinting that actually encourages movement, because a lot of splints for the hands just get in the way of movement, which is why we like the tape. Now, admittedly, tape on hands can be a real mess every time you wash them, so we do have to advocate sort of antibacterial wipes for a lot of hand cleaning, but the tape goes on the back of the hand, it goes across the fingers, so that they don't get quite as mucky, and it can actually increase the movement of the fingers quite dramatically. So try and find yourself somebody who knows something about some taping.
Excellent. Okay. We've got, our son is 2 years old with SMA2 on Spinraza, 4 doses already. What is the best for him? He keeps strongest. We do physio every day, but what can help him to hold his head when he is on his belly? What can help to push him to walk? If possible, we are believing he can do it. Each day gives us something new.
What we're using more and more of is what we call a peanut, and that's a therapy ball that's shaped like a peanut. It's a really lovely piece of equipment. If you haven't used one, it's great fun. You can sit and straddle and sit on it like a horse. You can go over the narrow bit. You can go over the top bit. You can have a sibling sitting on it and work your balance. There are a lot of things that you can do with a peanut. They're great things to work climbing over it. You can't do these on a therapy ball. Peanuts cost about 15 quid on Amazon. If your physio doesn't know anything about it, just go and grab one and play with it. It really is a great piece of equipment. We love them. We're really into peanuts. They're good fun. There is so much you can do with it. It's a lovely, lovely adjunct to physio at that age, at that stage. And great for a kid who's on Spinraza, because it really does show a lot of new things to do. You can use your legs, you can use your arms, you can use your trunk and your head.
Great. Okay. Right. Last two questions. I promise this time.
It's fine.
If the thighs won't straighten, is this more to do with the hips?
The hips and the knees can't be separated. This is the problem. Hip contractures actually often follow knee contractures. If the knees bend in bed, the hips have to bend. If the hips fall out to the side, then the knees will bend. You don't have your hips falling out to the side with the knees straight. So you cannot separate hips and knees. Thigh tightness is a knee and a hip problem together. This is why we need to do the stretches together. So we like hip and knee stretches. We like tummy time if they can tolerate. We never do tummy time for a child who can't tolerate it. Again, it's a great way to stretch over a peanut, or a therapy ball is a great way of doing hips and knees together. Standing is a great way of doing knees and hips together. Certainly don't try and separate knees and hips. They're all part. The muscles cross both. The hamstrings and quadriceps muscles are both two joint muscles. A lot of the abductors, the ones that run down the outside of the leg, the ITB, the iliotibial band that pulls the legs outwards, a lot of tightness there in frog sitting. It's all two joints. Don't try and separate hips and knees. It needs to be seen as a leg rather than two separate joints.
Great. And last but not least, who do I go to if my pediatric team refuses these services? I want it all and fight endlessly, but they seem to have given up on my child. What can I do to complain, or who can I write to?
There's several routes. The first one is your neuromuscular physiotherapist at your neuromuscular service should be helping you. That nobody should ever give up on these kids. What tends to happen is they're not seen as children who will progress, so they're not given any help. It's madness. But one person who should be helping is your neuromuscular specialist physio. The next people that you go to are the head of the therapy team, your actual therapy lead. Now, virtually everywhere, because this is a big government push, every single pediatric practice should have a therapy lead. They will be head of OT, physio, speech, everybody. So contact your therapy lead and demand a meeting with them to find out why they're not getting. And the last group you go to is what you call your CCG, your community council, and they are the people who hold the funds. And if you are not getting any satisfaction, you go to your CCG and say, why is my child not getting therapy? So those are the three people to go to: your neuromuscular specialist service, your head of therapies, your AHP lead, and your CCG.
And just as to add to that, if you are looking at complaining to your CCG, most of them have something called a patient advocacy and patient advice and liaison service. So
that's the hospital have a PALS service, yes. But the CCGs, yes, there is usually somebody, a sort of ombudsman that you can complain to.
Cool. Brilliant. Well, thank you very much. I want to read one comment, which I think sums up what everybody has been saying this evening. Marion, you are wonderful and have given me a renewed vigour to try again to keep my daughter moving instead of being made to feel I should just accept that we are fighting a losing battle. It is emotionally exhausting being a parent of a child with SMA. And there's been lots of positive feedback and thank yous throughout the session, so I think everybody's really got something out of this. So
let's put it this way, Andy. One of my big issues is I'm only an expert because the parents and children have taught me. Everything I know belongs to them, not to me. It's not for secret, it's not for keeps. I really delight in sharing with people because it belongs to all of us.
Brilliant. All right, well, thank you very much, Marion.
Exercise next time.
Yeah, absolutely. We're doing this monthly, so I'll see you at the end of November.
Lovely. Perfect.
Thanks a lot.
Thanks for all your help.
Take care. Bye-bye.
Thanks. Bye.